who don't know me, I'm Dr. Bhavani Srinivasan. I'm the Women's Forum co-chair along with Dr. Anjana Samadar, who's the chair. I'm also the vice chair for National Board of Trustees. And in my home turf in Long Island, I'm past president of RP of Queens and Long Island and the chair for Women's Affairs, which I have been for the past 5 to 6 years. February is actually Heart Health Month. So although we have started March, we felt that this was an extremely important topic, especially for women who are often extremely unaware of how fatal and how incapacitating heart disease can be in their cohorts. And heart disease actually refers to several types of heart conditions, which includes coronary artery disease, as well as heart attack or myocardial infarction. So we have two expert physicians here in this field who are going to be shedding clarity on these extremely important issues. But before that, I want to introduce an extremely a VIP among all you VIPs, and that is the president of API, Dr. Sudhakar Junalagada. Please put your hands together for Dr. Junalagada.
Thank you, Dr. Bhavan Srinivasan, for a warm welcome. Welcome you all. You all know that this year, the Women Physician section did a remarkable job, and they did several seminars and webinars, and they're going to have a live meeting going to happen in Clearwater, Florida, March 20th. And I'm sure you all are going to join and looking forward for the exciting meeting. You all know that heart diseases in women is as much as heart diseases in men, which I'm surprised to know that. I thought maybe they have less incidence. And API doing the community outreach program every month, last Sunday of every month through the media ZTV. And this was done already last month, by our experts in API. And I think I listened to that. Actually, it's good. I think it's a very important topic to discuss today. I'm sure, Bhavani brought this excellent speakers, and Dr. Malhotra, a good friend of mine, Dr. Vinny Jayam. Dr. Malhotra just took gavel for the president of New York APQL, and welcome. And Dr. Vinay, welcome. And again, further ado, Bhavani, back to you.
Oh, thank you, Dr. Sudhakar. That was lovely. And now I want to spotlight our very own Jhansi Ki Rani, Here's the dynamic, the beautiful, courageous chair of the Women's Forum, Dr. Anjana Samadar. Drum roll, please.
Thank you. Thank you, Bhavani, for the gracious introduction. I wanted to thank all my team, my whole team, including my co-chairs, Dr. Srinivasan, Dr. Kusums Punjabi, and Dr. Eramali, and my advisors, Dr. Uma Junlagatta and Dr. Udaya Shivangi. These people have stood by me, and they have helped me organize great events, great Zoom meetings. And at every meeting, we have portrayed women physicians and other members, great speakers and other members of our organization. It has always been our goal not believe in self-promotion. Each of the members you'll see have promoted other women physicians in the organization. And I'm so proud of all of you. That being said, I'm also going to be contesting for the position of vice president this year. And I would like to request all of your support and help. And also this talk is very close to my heart, because I lost my brother about 10 days back from cardiac arrest. And I think this is an important part we all tend to overlook. And I think it is so important. And we should all be cautious and be aware that this is such an important issue. And Dr. Malhotra and Dr. Vinny will be hosting a great interactive session today. And I'm sure it'll be enjoyable to all of you. Thank you.
Thank you, Anjana. Always great to see and hear you.
Thank you.
I would be amiss if I didn't recognize my BOT chair, Dr. Sajani Shah. I think she's here in the mix. And our president-elect the very glamorous and lovely Dr. Anupama Gotimukla. Anupama, I know I saw you join. So, would you like to say something? Anupama?
Yes. Thank you, Bhavani ji, and thank you to everyone. And looking forward for the wonderful session by Dr. Abhay Malhotra and Dr. Vinny Jayam, good friends of us from QLI, and great to see them back again. And we are looking forward for your talks without wasting much time. And I hope everyone enjoys the talks and much needed talks for women in this forum. Yeah.
Thanks, Anupama. Very, very graciously said. So, and now we are on with our program, which you've all been waiting eagerly for. We have an extremely eminent cardiologist. What happened to my screen? Suddenly it handsome guy. Okay.
Is that your son?
No, I don't know how he suddenly got in here. Okay. I want you to introduce a very eminent cardiologist in Long Island, Dr. Abhay Malhotra. He's a practicing cardiologist, chief of division of cardiology, St. Charles Hospital. He's the president of API and Queens Long Island organization, just took over in January. I don't know how to get my picture back. I don't know how to get the picture back. Vijaya, can you do something? I don't know what's happening with the screen.
No,
So
we
Dr.
are able to.
Bhavani,
We are able to see you, Bhavani.
now we know what pictures you have on your computer.
He's Dr. Malhotra is board certified in cardiovascular diseases. He's member of the American Society of Nuclear Cardiology, the member of American Society of Echocardiography, a member of the American College of Cardiology. So please put your hands together and welcome tonight our esteemed guest speaker, Dr. Abhay Malhotra.
Thank you, Bhavani ji, for the nice introduction. And it's so good to see and talk to all of my friends from National API. And I congratulate the whole team to put up this show. And hopefully by the end of this show, we will be able to increase the awareness of heart disease, especially among women. And today's topic is more related to cardiac issues with the women. So that's what we're going to discuss about. As you can see, we're all wearing, some of us are wearing red. That's the way to go. Go red for the women. That is a logo. And as Dr. Bhavani said, February is supposed to be the American Heart Month. Actually I was looking into it, was started by Dr. Lyndon Johnson in 1964. And since then, every year it has been February Heart Month, which is great. As we all said, cardiac disease or heart disease, when we mention heart disease, 90% of the time, we are talking about blockages in the heart arteries or coronary artery disease, which result in complications and can cause problems. It is the #1 killer in women. As you can see, every third or fourth death of women is related to heart. For some reason, there was a survey done, and less than 40% of the women said they thought that the breast cancer is more important and women die more of breast cancer rather than this. So this is a myth which actually needs to be clarified. And the fact is that cardiac heart disease is #1 killer, and we should be more aware about it. At present, every 1 in 16 women will have some kind of coronary artery disease, and they should be aware of it and go for the diagnosis and treatment on an early basis.
So Dr. Malhotra, I was going to ask questions, is that okay?
Yeah, sure, absolutely.
Yeah.
Let's
so,
do it.
So heart disease, #1 killer for women. Is that a myth or is it fact? Do more women die of cancer or of heart disease? Could you tell us a little bit about that?
Yes, absolutely. As I mentioned before, it is basically not the breast cancer. If you look at the statistics, breast cancer death is 1 in every 27 women, but for cardiac death is 1 in every 3 to 4 women. So which is much more serious thing. At present, 6.6 million women suffer from heart disease, and close to 300,000 women die every year from heart disease. It is a grave situation. We need to work on it. What's your next question, Bhavaniji?
Well, I wanted to know, a lot of women feel that, especially young women, that the estrogen is going to protect them. So is it that it's more common in postmenopausal women, or would you say that there is incidence in young women as well?
Okay, it's a good question. As we know that the incidence of cardiac or coronary artery disease related problems tend to rise significantly in postmenopausal women. And it actually then later on surpasses the incidence in men. Women are protected to some extent with estrogen before they get to menopause age. Estrogen tends to have a very protective action on our vascular endothelium. In other words, it doesn't let endothelial dysfunction happen, and that's how women get protected for it. But recently, it has been seen that the age of 45 to 54, the incidence of MI has gone up. And reason for that is they have now more gray risk factors in the form of smoking, depression, diabetes, which increases the incidence even in premenopausal women. But yes, to some extent, estrogen does affect premenopausal women.
Ah, okay. So, can you tell us why, women do worse when they get a heart attack? Why is that?
So this is also a very well-known fact that when women get heart attack, their comorbidities, their hospital stay, their mortality from that is more than men. Couple of this is because of biological factors that coronary arteries are smaller in size in women as compared to men. So when we do coronary interventions like any kind of stenting or doing any bypass surgery, it is sometimes it does not result in favorable effect. And also bleeding complications for some reason in women is higher as compared to males. They have done studies which have shown that if women get first heart attack, they have 27% of dying within 1 year as compared to 19% for males. And this discrepancy continues up till 5 years. So as I said before, that's why we should have more awareness so that they can get early treatment. The reason why they can have problem with heart attack is they tend to present later in the phase of the heart attack while they are getting it. One of the reasons we'll discuss later on is they do not get very typical symptoms of angina or heart pain, what males do. So that is one of the reasons for their delayed presentation for heart attack for the treatment.
So you did mention smoking just now. So that would be one of the risk factors for women, because they are the men are stopping smoking, but the women are taking it up, right?
Absolutely. And actually, so there are certain risk factors which is common for males and females. But as our topic is more related to focusing on women and heart disease, smoking, when women start smoking, the incidence of heart attack goes even higher than males, those who are smoking. So they have a worse prognosis. Second thing, also in smoking, it has been shown that they have less efficacy in quitting smoking, and they tend to get withdrawal symptoms of quitting smoking more than males because something related to menstrual periods. So yes, they should not be smoking, absolutely, because if they do, they are even in a worse situation as compared to a male smoker. So that definitely contributes to it. The other two risk factors, which is common for males and females, is diabetes and hypertension and hyperlipidemia. The difference between that is for women, For males, we basically talk about LDL, which is low dense lipoprotein, being a risk factor. But the studies have shown that for women, it is low HDL, low levels of good cholesterol, which is high density lipoprotein, and the triglycerides, which plays a significant role in morbidity in females. And so obviously, quitting smoking and eating healthy and doing some kind of physical activity will help, which will help to raise HDL level.
Yeah, so the HDL is cardioprotective. So that's as much as possible, they should boost that.
Right.
Yeah. So I've heard the phrase broken heart syndrome. So apart, I know we had Valentine's Day in February, but what is broken heart syndrome?
Okay, well, that's a good question, Bhavaniji. So what we are also now talking about, and a lot of research is also going on, is for women, they are having more psychological issues, anxiety, stress related, and depression is more common, which has been also underdiagnosed. And these are also the risk factors where you can have heart attacks and can have problems. Broken heart syndrome is kind of a syndrome where if somebody is very upset, have lost their job or got a divorce or something else, somebody dies in the family, because of adrenergic surge or sympathomimetic activity, the heart can get weaker. These patients, they basically they present like a heart attack kind of picture. They will have some EKG changes. They will have some chest discomfort also. And the blood troponins, which is a blood test to look for any heart attack, that is also positive. But when you do angiogram, you see that they don't have blockages in the heart arteries. It's just their heart got weaker. And the reason for that is, as I said, it's something related to adrenergic surge or sympathomimetic activity, which is related to stress, acute stress. And the good news about that is the pumping action of the heart, weakening of the heart muscle does get better with time, within 6 weeks or so. But this is very high incidence in women as compared to males. You don't see broken heart syndromes in males. It's actually, I think, 2 to 3 times higher incidence in females as compared to males.
All right. That's very interesting. And talking about pregnancy and chest pain, should one worry when a pregnant female patient gets chest pain?
Okay, so the other biological factor which we should discuss about is, in women, as I said, one thing is that their coronary arteries are smaller in size, that's why they can run into trouble. Second thing is, when you develop plaque in the coronary arteries, when you develop blockage in the coronary arteries, in males, it tend to cause plaque rupture. And then they present with we call it a SC elevation MI, and they get reperfused right away. For women, it is more of a plaque erosion rather than plaque rupture. That's why they come more with non-SC elevation MI and tend to get a lesser invasive therapy and can have more complications from it. Another very important aspect is that women have more chances of getting, we call it as a spontaneous coronary artery dissection. What it is that the coronary arteries are okay, they are normal, they don't have any plaque, but they tend to have an intimal flap and then dissection. Especially in pregnant females, if they come in with chest pain, we should keep a very low threshold to get investigations done. You should look for 3 things if they have chest pain. Either it could be MI, which could be because of coronary dissection. Second thing is look for pulmonary embolism. Third thing is aortic dissection is also seen more commonly in women. So we should look for that. So with the women saying that she's having chest pain, we should at least get an EKG done, blood troponins, echo if need, to rule out workup for pulmonary embolism. And coronary dissection actually is common in young females, especially in pregnancy, which because they don't have any plaque buildup, but they can have coronary dissection. It is actually more common in connective tissue disorder patients, those who have Marfan syndrome and all that.
So I know there's a lot of people are on the baby aspirin, you know, prophylactically. In a person, in a regular female, you know, would you recommend the baby aspirin just on a regular basis? And B, what medicine will you avoid in the pregnant patient whom we talked about a little bit earlier?
If they need, anybody has a heart attack or any active angina symptoms in pregnancy, none of the medications are category A. That means they are the safest, but aspirin, low dose aspirin, it should be okay. They could be given. Low dose beta blockers can be given during pregnancy. The medications which are completely no in pregnancy is ACE inhibitors that definitely should be avoided. Also, statins is preferably should be avoided. If they have an issue with hypertension during pregnancy, then we have methyl-dopa, labetalol. Those are the medication which can be used intravenously to lower the blood pressure. Also, women, those who have biomechanical valves or valve issues, sometimes we should be avoiding Coumadin, especially first trimester and the third trimester, and put them on low molecular weight, Lovenox. It's like a heparin injection, subcutaneous injections to protect so that the mechanical valve doesn't get thrombosed. So these are the outline. I mean, it's a big topic to start with, but these are the medications you should avoid. Low dose aspirin should be okay without any problem.
And on the same issue of medications, do calcium supplements increase the chance of MI too? Do they increase the incidence?
It's actually is a little debatable. As you know, in the recent past, you know, there were studies coming out that a lot of women post-menopausal have been given a lot of calcium for osteoporosis to strengthen their bones. And there are a couple of studies came up. One was the National Health Initiative with the calcium and vitamin D, showing that there was slight increase in risk of having a heart attack. The incidence of heart attack was more in women, those who were taking a lot of calcium supplements. But some of the studies, so it is kind of a debatable. At present, what they are saying is that definitely we should not be popping calcium right away, supplements like that. If you want to take, you should take dietary calcium, which is actually safe. Supplemental, if you want to take, you should not go over 1,000 milligrams a day. You know, 1,000 milligrams is like 3, sizes of any dairy product, that kind of stuff. So we should definitely avoid giving a lot of calcium. Calcium is not good for vascular thing, and also it tends to cause blood cells, platelets to get stickier. So it's not that they should not take it, but they should be cautious.
Yeah. Not a lot to think about. But then on the same topic of medications, exogenous estrogen, what is do you think that has a role to play?
No, actually. So as I said, post-menopausal, the incidence of heart attack goes up because their estrogen levels go down. But multiple studies have shown that taking or giving exogenous estrogen preparations does not help. So it is not to be given to women. The other thing which I want to mention, as I said, was some atypical symptoms for angina or heart attack in women. You know, typical symptoms what we see in males is having crushing kind of a chest discomfort, which then can go to the jaw, to the back, radiate to the arm, associated with a lot of diaphoresis. Women, sometimes you will get surprised to see they can only come with fatigue, that they have been feeling more tired without having any other symptoms. They can have upper back pain. They can have a little bit of fullness in the chest. they can just have little nausea or vomiting, some epigastric upper abdominal discomfort, or they can have some dizzy spells. Fatigue was actually in 30% of the patient coming up just with fatigue. So that's the reason in women, even if they have atypical symptoms, which you think it is not MI, we should have a low threshold and get the investigations done right away. Also, we got to do some more studies and do some programs to make this thing aware to women that they should not think, oh, it's atypical pain, this could be stomach or something else. Once they have symptoms, they definitely should take medical advice right away. That will definitely help to get their timely help for heart attack. So this is also one of the issues why women show up late for treatment with the MI. The other thing is that, you take any studies, the women have been underrepresented, understudied, and has been underdiagnosed as well as undertreated. So you take either invasive treatment in the form of stenting or even the medications. There are studies showing that women have been undertreated. So that is an aspect which we need to work on so that we can improve the mortality and morbidity for women in MI.
So are there any programs that you would recommend to bring home this, the heart disease in females, the incidence and right. So on? Is there any program that you'd recommend, Dr. Malhotra?
Well, there are a couple of them which actually is funded. One is funded by CDC, which is WISE Women. That is an acronym which is well-established screening and evaluation of women across the nation. What they are actually trying to do is they have already been set up. They are going to low social economic status. By the way, so far as ethnicity is concerned, in women itself, African Americans for some reason have to tend to have a higher incidence of heart disease as compared to white people. And WISE women, especially, they are looking into it. Low social economic status. They are going there, making them more aware, checking their blood pressure, checking their blood sugar, cholesterol, and that is one of the program which is working on it. Plus, American Heart Association, as I said, they have done this red for women, and there are other programs also. If you see cdc.gov, they are doing it. There's another one which I think of as a Million Heart Program. Their role is by 2025 to cut down 1 million heart attacks and strokes more in women as compared to males. So there are certain projects going on, but what we need to do is we need to do more studies which are focused mainly on the female gender and the heart disease specifically in the females. We are lacking that. We should do that more in the future.
So would you be possible to email the programs to me, then I can share them with our audience?
Absolutely, I will do that. And I think I'm taking a lot of time, Bhavani ji. Is my time over, or?
Yeah, we're just about. So, but thanks so much. This was very illuminating.
Thank you. I have a pleasure to be with Dr. Vinny Jayam, my dear friend. And he's an EP guy, so we'll be talking more about strokes and atrial fibrillation. Thank you, Bhavani ji, and thank you everybody for listening.
Sure, yes, our pleasure. Thank you for such an illuminating talk. We lot of myths and misconceptions. You've cleared up a lot of that. Yeah, thanks again. We won't let you go yet because we're going to have a Q&A at the end in case somebody has something to ask you. More apart from the questions which I put up. So here we have Dr. Vinny Jayam, another eminent cardiologist in our area. Dr. Jayam is going to be our president, is our president-elect and will be president next year. He is one of the leading cardiac electrophysiologists in Long Island, New York. After being a state ranker in school and college, he graduated from Coronary Medical College in India as the best outgoing student. Dr. Jayam received further training at places including Henry Ford Hospital in Detroit, and Johns Hopkins Hospital. In his practice of electrophysiology of over 17 years, he has performed thousands of EP procedures. He is one amongst the highest implanters of cardiac devices in the United States. A prolific writer, Dr. Jayam has authored and co-authored numerous articles and chapters. He has contributed to the work of publication of practice guidelines by the AHA and by the American College of Cardiology. He's authored a chapter in electrophysiology in Hurst's textbook of cardiology, and he serves on the editorial review boards, conducts training on advanced cardiac electrophysiology, and he speaks regularly throughout the country on heart arrhythmia. He's recognized nationally in cardiac EP and consults on the use and development of defibrillators, pacemakers, and other devices to regulate the heart. He's a family man with a passion of giving back to the community. He leads medical teams onto several trips across the globe and to India on charitable missions, and performs cardiac procedures and surgeries for patients from low economic background and training physicians to carry on such work. He's going to talk to you today about AFib and stroke risk in women. So I think he's going to be screen sharing. So Vijay, yes?
Thank you so much for your introduction is almost like a speech. So thank you very much for that. So I'm going to do a slightly different format.
Okay.
By the way, congratulations to all the brave women, including many of you here who have gone through life and strive together to be in a position of where you are. From being the other side, we thank you profusely for all that you do every single day. Having said that, I'm going to share my screen. Okay, I hope you can see that. I know this is about a cardiac women forum, but I think women are no behind men in competing for their share of disease. So their understanding is like what disease in men would be, and I would be stressing on certain bullets about where they are slightly different than men. Okay. My outline will be this as follows. I'll introduce the topic. We will discuss briefly about strategies to lower the risk of thromboembolism or stroke cardioembolism, role of particularly left atrial appendage and left atrial appendage therapies, something that many of you may, I don't know the backgrounds of many of the participants here, so I made it look very simple, something that they many a time watch on TV and may wonder. So I made an attempt to shed some light on. Many of you may know, stroke is the 5th leading cause of death in the United States. Around 1 in 20 deaths in the US are due to stroke. Every 40 seconds in the United States, someone has a stroke. And every 4 minutes, someone dies from a stroke. These are staggering statistics. And what is even staggering is atrial fibrillation is as powerful a risk factor for stroke as it gets. AF increases the stroke risk almost 5 times in all age groups. Strokes attributable to atrial fibrillation increases with age from around 1.5% when you're younger, below 60 years, to almost 25% when you get into the 80s. So it's a very relevant thing. Strokes are extremely debilitating, as this slide shows. An AFib-related stroke is almost twice as debilitating as non-AFib-related stroke. As this slide shows, 70% of atrial fibrillation-related stroke result in either death or permanent disability. Quite a staggering reality. Now, how are women different with AFib? Women are more likely to have atypical symptoms with atrial fibrillation than men. And what are atypical symptoms? What can be the typical symptoms of atrial fibrillation? Something like palpitations, shortness of breath is what men present very commonly with atrial fibrillation. Women have the same symptoms, but they can have more non-specific symptoms like fatigue and weakness. The frequency and duration of AFib is more frequent and longer lasting in women for whatever reason. Women tend to be older at diagnosis. Henceforth, they have different types of comorbidities. Women have hypertension and valvular heart disease as more common comorbidities with AFib, less than men who have coronary disease as a common risk factor. Women undergo, for the same reason, ablation much less often than men, and something Dr. Malhotra was mentioning too. They participate less in trials, participate less in therapy, and they postpone their own treatment. When they do proceed for ablation, they tend to have AFib longer and hence need more complex procedures. How do we lower the risk of stroke? The prime therapies we have at this time are pharmacologic and non-pharmacologic. Use of anticoagulants is one prime therapy. Use of aspirin, antiplatelet therapies, use of Coumadin, and newer NOAC or newer oral anticoagulation coagulants. Rhythm management is also goes in tune with, as you lower, common sense says, as you lower the fibrillation, the risk of stroke will be lower. So rhythm management is an integral part of this, although not with permanent proof yet. Left atrial appendage therapies, including Watchman Device, Lariat Device, you have probably heard on TV or from colleagues, and I will show you or touch upon these. If there is one slide or if there is one piece of information that any of you can learn from today's talk, would be to understand something called the CHADS-VASC score. I don't know if you can see my mouse. The CHADS-VASC score stands for the following acronym. C stands for congestive heart failure. You may surmise what is congestive heart failure these days. The trials have described congestive heart failure many decades ago. And what is that? Symptoms of a typical heart failure being shortness of breath at rest, exercise, or fatigue, and signs of typical heart failure like tachypnea, pulmonary RALs, pleural effusions, and so on. So these are something we have read in Hutchison back home in our med schools. Simple signs and symptoms of heart failure are still used even in current guidelines in treatment of several different things. So CHADS-VASC score stands for congestive heart failure, hypertension, age over 75 years, diabetes, stroke, vascular disease in the form of presence of prior myocardial infarction, peripheral arterial disease, or even presence of aortic plaque when they do a carotid artery, carotid ultrasounds or echocardiograms and visualization of plaque in the aorta. That in itself will qualify as presence of vascular disease. Age, obviously over 65, and sex. This is something where I want to stress on. What female sex was not a risk factor, was not perceived to be a risk factor in the past, has been upgraded as a risk factor, and I want to shed some light on that. Why is that? So, like I mentioned to you, the prevalence of AFib in women over 75 is twice that of men. Think about it. The incidence of atrial fibrillation in men is more than incidence of atrial fibrillation. But the prevalence, meaning incidence is per 100. If you take 100 individuals, more men will have atrial fibrillation. But if you take the population, there are more women than men after over 75. So if you add them up, women are twice than men to have atrial fibrillation because of their longer lifespan. Twice as many women die of stroke as breast cancer. I see that we were talking about breast cancer and risk of, and as perception by women as most important thing, more important thing than coronary disease. Remember, just from AFib alone, twice as many women die of stroke as breast cancer. AFib being an important part of it. Women with AFib has higher thromboembolic risk than men, often due to the presence of being diagnosed at a later age, hence having associated with comorbidities like hypertension. Also, some interesting parts about women, and it tells the story about what women has been. More women than men are stroke caregivers. In fact, I think as far as caregiving is concerned, women are mostly caregivers. Men are caretakers. Women are less likely to participate in clinical studies than men. And get this, European Society of Cardiology also described this. Women call ambulances for husbands, for fathers, for brothers with heart attacks, but not for themselves. This is scientifically identified. It's not just ethical, moral, or societal norm, but it is a scientific data. So women has to take care of women, but they don't. Women's risk with stroke. Women with AFib have higher thromboembolic risk, like we discussed, especially because of greater prevalence of hypertension than men. Risk due to sex continues to stand out even after factoring for all types of comorbidities, and hence, in the current practice guidelines for AFib management, female sex in itself is a risk factor. Why would that be? It could be because of increased thrombogenicity due to hormonal differences, procoagulant qualities, including raised markers of endothelial dysfunction and prothrombotic factors, elevated levels of von Willebrand factor. There's so many things that have been described, but we don't know exactly one specific reason why. The guidelines do make a point, though. The current guidelines do make a point that female sex without any risk factor. So the understanding is females are at a slightly higher risk of stroke than men. But as far as treatment of a stroke prophylaxis is concerned, guidelines make this clear. Without any other risk factors, female sex in itself is not a higher risk of stroke. So, but when you have other risk factors, female sex immediately adds up to it. The other thing that we notice, me being an electrophysiologist and my perceptions are skewed, one of the common misconceptions or lack of perceptions in the society is what is valvular heart disease as described in the context of atrial fibrillation. You may have seen several TV commercials about Xarelto, about Eliquis. These are the newer oral anticoagulant agents. They make it very, very clear in non-valvular AFib patients. And why do they make it so clear? Is AFib therapies have been only tried in non-valvular AFib, but that's where the misconception comes up. What is valvular? Valvular AFib, the guidelines make this very clear, and this is the second point I would like for you to remember. The first is the CHADS-VASc score. The second is this: don't overcount valvular heart disease. AFib in the setting of only moderate to severe mitral stenosis or presence of artificial mechanic valve is called valvular AFib. Presence of aortic stenosis is not a valvular AFib. Presence of mild valvular heart disease is not valvular AFib. For that matter, presence of mitral valve surgery in itself for a biased prosthetic valve is not considered to be valvular heart disease. So you can use the newer oral anticoagulants for many, many more than what is perceived by many cardiologists. So leave alone non-cardiac practitioners. So this is the second point I would like for you to remember today. So what are the proposed mechanisms to lower the stroke risk? We mentioned about use of aspirin and oral anticoagulants. This is where the CHADS-VASc score come into play. If the score is less than 2, in other words, 0 or 1, either if the score is 0, the guidelines say you don't even have to use aspirin. If a 50-year-old male or a 40-year-old female, or a 50-year-old female for that matter, with no risk factors comes to your office, you don't have to give aspirin. Again, people overtreat this. Guidelines are very clear. The reason I mentioned guidelines and guidelines multiple times is we want to practice guideline-derived medical therapy. Not only because it is tested and appropriate, it may go into the metrics of your practice. with current day medical, electronic medical records, all what you do is being mined by corporations to qualify you, to quantify how you practice. So practice of guideline-based medicine is very, very important. I don't have to overstate this to this elite crowd. So if the CHADS-VASc score is 0, no anticoagulant, not even aspirin is required. If the score is greater than or equal to 2, then only then you use oral anticoagulants. Warfarin, as many of you know, is a very age-old anticoagulant, has been in use for a long time, but it is mired with so many inadequacies, some of them being, which lead to non-compliance, basically. 44% of the patients, see, you have to balance the therapeutic window of Coumadin between 1.8 to 3. And if it goes slow, 48% of the thromboembolic events can occur. And if it goes more than 3, people can bleed. So in order to titrate warfarin in this short window makes it very, very undesirable. It has been the bane of our existence for quite some time until the onset of this newer oral anticoagulant agents. That's what we call as the DOACs, or direct oral anticoagulants. Again, I don't want to burden this crowd, or neither is the time to describe different type of anticoagulant agents, but sure enough, there is enough data to show that not just warfarin, but the other anticoagulants are also very difficult to continue. And there are so many reasons why they could be discontinued. 83% of the patients who are treated with anticoagulants for atrial fibrillation would be willing to try a different treatment. Why? It's a nuisance. Bleeding is a risk, is a nuisance perceived by the patients. And when it comes to newer drugs, the costs are prohibitive. It is not uncommon that a person with fully paid drug plan will be paying $400 or $500 out of the pocket per month for use of anticoagulants. So this is extraordinary burden on patients who are already in an age where they cannot have a sustainable income to continue different types of multi-pronged medical therapy. It's very hard to continue. A very common cause for discontinuation of the drug, and non-compliance lead to complications. This slide shows how often these drugs are discontinued based on, again, medical evidence. Xarelto or rivaroxaban is discontinued almost 1/4 of the time. As you go down the list, 1/3 of the time, the drugs have been discontinued for a multitude of reasons. Hence comes the non-medical ways of reducing the stroke risk. And where will that come from? This is a transesophageal echocardiogram of a left atrial appendage with this structure that comes in and out of the view is a soft forming glue-like structure, is the clot. Left atrial appendage within the heart is the prime source for harboring is the prime embolic source to emanate from the heart. So as evidence shows, left atrial appendage harbors clots in 57% of valvular and 90% of the non-valvular cases of atrial fibrillation. Why is that? Because of the specific shape of the left atrial appendage, presence of trabeculations, and it's not a very muscular structure. So the decrease in the blood flow will make the blood to pool, and pool blood can clot. The pectinate muscle morphology, and there is descriptions biochemically of AFib-related inflammation. All of this will add to the inflammatory, to the nidus of the clot formation, as you can see in this video. We went through this. There are different types of shapes of left atrial appendage, which is completely beyond. You may hear this amongst your patients. I don't think you will ever have to know these things, but you will hear cactus, cauliflower, chicken wing, and so on. The reason I mention this to you is to show there is these, you see the percentages. 48% this is the most common morphology, but that is the least risky for thromboembolism amongst the different morphologies of appendage. Chicken wing morphology here is the least thrombogenic of the left atrial appendage. Anyway, this is beyond the scope. Okay, so I just want to spend a moment here on this slide, and please follow me here. Exclusion of the left atrial appendage. So if we think 90% of non-valvular AFib is from left atrial appendage, why the hell can't you just eliminate it? Take it out from the picture. That's where these therapies come from. And they can be done two ways. One is surgically. When someone opens the chest for any reason, then you can go and either remove the appendage or ligate the appendage. And that's where one of the most common things that has been used by surgeons today are AtriClips. And I'll show you a picture. And then the percutaneous devices, where a person like me come into play, where we go from the groin and deliver therapies into the heart percutaneously, doing the same thing that the surgeon would do with an open chest. Here's a video of an AtriClip. Mind you, this is just an animation. This is the left atrial appendage being held, and this is a clip that is going on both sides of the appendage. And once the clip is delivered, as you can see, the left atrium is isolated and it will not be any source anymore for the formation of the clot, and the rest of the left atrial appendage will shrivel and fibrose off and will no longer act as a nidus for infection. Excuse me, nidus for clot. Okay, so that's the surgical AtriCure clip. I don't want to burden the audience with different types of surgical therapies. I just want them to have a visual of what in the world they talk about when your patients come. And here is what we call as a Lariat device. Lariat is a percutaneous device. We have two axes. One is transvascular and also an epicardial axis, as you can see in this video. This is the left atrial appendage. We access from endocardially from the vein. We go transeptally across the atrium and put a wire into the left atrial appendage. So the next axis is here. We access the pericardium and put another wire that can go, and you'll see it in a moment. This wire, the tip of this wire and this wire have magnets on. They can go attached to each other and form a railing for the next step, for the suture to go on top. Again, I don't want, this is a very technical slide, but I think it will give you a very simple common sense that was used in designing this very, very interesting therapy called Lariat device. By the way, this Lariat is basically a suture. It was approved by FDA for a suture. It's really still not approved by FDA for left atrial appendage closure. Hence, it has not become as popular. And again, technically, it's much more difficult than others. Hence, it has not become as popular. So that's the Lariat device. And that brings you to the Watchman device. I'm sure this is what a lot of people have heard on TV or with the patients or themselves are knowledgeable. What is a Lariat Watchman device? Is a purely endovascular device where you go access the atrium, you already went through the septum and go through the left atrial appendage. And this is the device. A device looks somewhat like a mesh size of a quarter or a dime. You go and settle it within the appendage and it gets endothelialized completely. So completely, when you see it later, once it is endothelialized, the Watchman device seals off the appendage once and for all. Hence, it will eliminate the focus of clot. There is enormous evidence shown up until now that Watchman device decreases the risk of stroke. Now, very soon, very, very soon, there are trials. In fact, we're part of very few centers in the country called the Champion trial, where we're recruiting patients to demonstrate that the Watchman device is on par with use of blood thinners or even maybe superior. When that day comes, every of your patients will be looking and asking for this Watchman device in place of anticoagulants. And that day is very common, very soon. Based on the current data, which I have several slides of, but I will not bother you. The current guidelines, again, I go back to guidelines, mind you, just to make a point. The guidelines currently have approved a left atrial exclusion device through the AtriCure with the video that I just showed you as a class 2B indication, and a Watchman also as a class 2B indication. Again, I don't want to bore this audience with the sequence of number of trials and so on. There are randomized trial data that support, even though this is a procedure, there's randomized trial data to show not only that they can decrease the stroke, meta-analysis of sub-trial data, further analysis of the data does show that even there is a mortality improvement in these patients because they are not suffering by taking the blood thinners, having bleeding complications and resulting in a lot of morbidity. In addition to this, this was the Watchman device before, and it has been improved into what we call as Watchman Flex device. I think it's a day and night difference, making this device much more safer to deliver. And I think this is a game changer. That is the details of which are beyond the scope of our talk, but this is what is going to change. The Watchman Flex is what is going to change the use of anticoagulants in the future. How about catheter ablation? All of you must have heard ablation as a catheter-based therapy used for atrial fibrillation. There is umpteen amount of data that is generated by use of AFib ablation. Is almost a 15 to 20 year procedure, and it has gone through numerous iterations and improvements because of more and more understanding of how this to be done and improvement in catheter-based technologies. So just like, remember how your iPhone was 10 years ago and what your iPhone is this now, how dramatically different that phone would be. Just like that, the technology we used 10 years ago is dramatically different and far superior than what we use now. Hence, if we compare a patient who got this therapy 10 years ago, it's like comparing apples with oranges. This is one of the technical difficulties, practical difficulties in recruiting a trial to a patient, which sometimes takes several years. The last patient that was recruited is an apple. The first patient who was recruited for the same trial with the same characteristics will be an orange. So we don't have a conclusive evidence to show that catheter ablation decreases the risk of stroke. Hence, the guidelines today, as of today, recommend catheter ablation only to decrease the symptoms, only to decrease for symptomatic benefit with atrial fibrillation. But there is, and if you ask me, I would prefer catheter ablation over drugs any day, because I know that it is less morbid, more successful compared to any day, compared to medications used for atrial fibrillation. And we do believe, we in the electrophysiology community do believe, although there is no conclusive data, that AFib ablation decreases the risk of stroke and probably improve mortality. The evidence will come. So far, we don't have a conclusive evidence in the form of a trial data. You must have heard also, we are beginning to understand atrial fibrillation as we know it. And one of the reasons is we don't know how to diagnose atrial fibrillation. People used to think when they go to a doctor's office and get an EKG, and if they're in sinus rhythm, oh, they're fine. They don't have AFib. But that's not true. They go home. We know that 40% of AFib is asymptomatic, meaning they don't even feel it. So one of the main problems with diagnosing asymptomatic AFib was how often do you monitor, how long do you monitor these patients? So we got implantation of a long-lasting loop monitors, and these have revolutionized our understanding of how much there is AFib and how much we have a reason to make an impact. So I threw it here for you to have an understanding of another dimension of AFib management. But again, this in itself could be a several-hour discussion. So in conclusion, I just want to, because we're talking about women here, I just want to conclude a slide to conclude about how AFib is slightly different in women than men. And we have dwelled on any of these points in previous slides. But the one thing that is very important to know is women don't proceed for their own treatment as much as they force their men to go for. And on today's I want to take this opportunity for all those listeners to, many of you are women, is to take control of your own health and put yourself also at least on par with your family members that you always care for. I thank you very much for your attention, and I think the forum will be open for questions.
Wow, that was fantastic, Dr. Vinny. You took us on this magic carpet ride of all the various modalities, and what was out there and what could be done and what shouldn't be done. Thank you. That was very, very educative. I think our audience loved it. I saw a couple of comments and they were just blown away. Thanks again. We do have questions.
It's truly my pleasure.
Yeah.
Go ahead.
We do have questions for both of you. So for Dr. Malhotra, somebody wanted to know about incidence of heart disease in India in Indian women. And is there more of an incidence here in Indian women in the US and India and Canada? So they wanted to know about, they want to know a bit about that.
Yeah, actually, that's a very good question. As you know, Asians tend to have more of a problem so far as coronary disease is concerned. But here in Indian Americans over here, the females have less incidence as compared to white population. One of the reasons why they're saying is they tend to have less of risk factors in the form of smoking, tend to be a little more aware of staying fit and watching their diet. But on the other hand, the Asian males, especially Indian males, because of two reasons. One is that their coronary artery size being smaller than the Caucasian male, and because the LPA level being higher genetically in Indians, their incidence is high. But for women, it is less.
I do have a point to make. As far as AFib is concerned and nationality, there is evidence to show that Asian women are not necessarily at higher risk of a stroke than, in fact, they're less risk of a stroke than Caucasian women. So the risk of stroke is almost same as women in multiple. This has been very well studied in Chinese more than Indians, but Asians are slightly better as far as AFib stroke is concerned. A great question.
Well, to both of you, what about the diameter of the coronary vessels? Does that not play a part? The smaller diameter?
Absolutely. So if it is smaller diameter, it actually can poses more complications during the procedure, like putting in a stent, as I said, or doing a bypass surgery. Smaller the diameter, harder the intervention, and sometimes outcomes are not that great. So that poses a risk as compared to bigger arteries. And females also, their heart, the cavities are smaller size as compared to males, which also is a little bit of a poses a high risk.
Thank you. Dr. Vinny, post TAVR with paroxysmal atrial fibrillation, regarding anticoagulation, could you comment on that?
It should be TAVR or transaortic valve replacement has no bearing on use of or the choice of anticoagulants. The choice is same as any other person. It is not considered to be one of those valvular heart diseases. So as far as use of anticoagulants is concerned, so you can use the newer Xarelto, Eliquis, Pradaxa, Daxman, any of those newer anticoagulants.
Mm.
And if anybody has TAVR done, but they are in sinus rhythm, you just give them anticoagulation for a short while post-procedure, and then later on you can take them off that if they are in normal rhythm, not in AFib.
And one of our attendees also wanted to know whether you can see left AA clots on the TT echo.
No,
No?
not reliably. The
Not
reason is, I tell this to patients, the heart is, if this is the atrium and this is the ventricle, the heart is aligned like this. So if you want to see the ventricle, you can do a transthoracic part from the chest. If you want to see the atrium, it is far away from the chest. It's deep inside, far away from the skin. So you need to go inside the esophagus to visualize the appendage. So in a transthoracic echo, you will not have the clarity, fidelity enough to rule out a clot. If the clot is very big, you can see it in any form of imaging, but you cannot reliably exclude a clot in the left atrial appendage, most importantly, from a transthoracic echo.
I see. So I think that was, oh, and one more question. Important role of CT calcium score?
So that is actually one of the latest modalities we have. Either we can do a calcium score, cardiac calcium score, or we can do a coronary CAT scan with contrast, which tells us about the blockages in the arteries. Calcium score per se, these tests usually are done for people, those who have low to medium pre-test probability for coronary artery disease. If the calcium score is usually less than 100, it's a good news. Then chances of them having any problems in the future is less. But if the calcium score is more than 100 but less than 400, that's kind of mild to moderate. You got to be more aggressive, controlling risk factors like giving them statins for cholesterol or even low dose aspirin. If the calcium score goes above 400, those have usually severe coronary artery disease and need to be further studied. So yes, it does have a role for low to intermediate pre-test probability. If anybody is presenting with very typical symptoms of suggestive of angina or blockages, I would rather do directly coronary angiogram and look into it if they are high probability.
Fantastic. Well, thank you both of you. That's just made our evening, you know. I'm so glad.
Bhavani, just give me 10 seconds.
Yes, Dr. Malhotra wanted to say a few words, so the floor is yours.
Yeah, no, first of all, I want to thank all of, being the president of APQLI. Thank you to all of my members. And I do see a few of the senior members here joined us for this event. I saw Dr. Shah is there, Dr. Kumar, Dr. Mehra, Dr. Jagdish Gupta, and obviously Bhavani is there with us. And I want to thank for all the support from the RPQLI member. As you know, we are the part of the National RP, and we will work in harmony in the future, especially for in this field, so that we can increase the awareness of heart disease in women. Thank you.
Thank you. I think there's one final question. Somebody suddenly popped this on the chat box about height and weight, obesity versus,
Right. So for females, especially also, what you're looking for is BMI, body mass index. And usually we recommend that it should be less than 25. You go by the waist size. So that should be less than 35. This is one of the criteria they look for. Those who have waist size less than 35, BMI less than 25, and they are physically active, not smoking, eating good food, they are in a much better position as compared to the other people, those who don't do that. Their chances of having coronary artery disease will be less. Even if they get, their prognosis is good. So it's all about prevention, taking care of ourselves.
Thank you so
Oh.
much. This was
Bhavani, if
somebody
you allow
saw
me. Okay.
a cardiac IQ test. Cardiac IQ test is, I think, Rita's question, right? So, is there she wanted to know about cardiac IQ test? I think that was. Yeah.
I don't.
Cardiac IQ tests.
We don't have the IQ to tell
I
that.
don't.
Is there anything like that?
So-
I haven't heard about it, but I just thought maybe
Never
it's
heard.
something there.
Bhavani, if I may add just a small comment.
Of course.
If you can be kind enough to, when you ask your audiences or get a feedback from whatever, to send our contact information. If someone may think of something, I've seen, again, I just tell from my experiences, I have gotten many doctors as patients more than getting their patients. As we all grow older, we also become patients. So if someone wants to privately ask questions about any of them, it would be my pleasure to answer their questions. And I can speak for my co-speaker that I would encourage you to give out our name or number if anybody has any question. It would be our pleasure to be of help. Thank you.
Oh, well, that's great. Thank you.
So,
Yes,
Winnie and Abhay, why don't you leave your email in the chat box? Probably the contact.
Sure, we'll do that.
And they can always contact me so I can put them in touch with both our esteemed speakers. That was fantastic. I just loved the talk by both of you, Dr. Malhotra and Dr. Jayam. It was just very informative, very educative. And it was, I think our audience learned a lot tonight. So, you know, and I think the women here this evening are going to take good care of themselves, aren't you girls? You know? So because they know that they have to do it for themselves and their menfolk, right? So, you know, I also wanted to say that in February we said was Heart Health Month, and March is Nutrition Month, you know. So, you know, so that it all ties in together, you know. See, unless you eat properly and you take care of yourself, you're not going to have good heart health, are you? So, you know, I'm going to call Dr. Udaya Shivangi to wrap up for us. And she has one or two upcoming events to talk about. Udaya, are you there?
Yeah, hi everyone. Actually, there is a couple of more questions too. I don't know whether Dr. Abhay, someone wants to know the role of homocysteine in developmental of heart disease.
Yeah, so they were talking about homocysteine levels. About a few years ago, a couple of studies came up and they said that this is a significant factor, but now they're not very much into it. So far as levels are within normal limits, we don't have to take it, and there is no direct correlation with the incidence of coronary disease with it.
Thank you. And there is one more question. Dr. Surekha from Texas, what preliminary tests are recommended to undergo determine the heart health, especially if there is a bit of heavy feeling?
So if, first of all, just feeling heavy or feeling fatigue could be, as I said, an atypical symptom of angina. If you do have risk factors in the form of high blood pressure, hypertension, diabetes, cholesterol, family history, smoking, you should talk to your doctor and get at least an EKG done, color Doppler echocardiography study, which can give you information about how the pumping action of the heart is, and get a testing, nuclear stress testing done. I also want to make one more point that we do stress tests in our offices. The exercise EKG stress test, also for women, it is less specific and less sensitive as compared to males. We get better correlation when we do the angiogram that those who are positive stress tests in males that they have disease, but we don't see that in females. So when you do for females, they can have a false positive results just by looking at the EKG. So when you do the stress test, we do a dual modality. Make sure that when they do the treadmill stress test, you look at the EKG, plus either you look at the echo or you look at the nuclear pictures, especially in women, it is very important.
Thank you so much. Just a last question. Important role of calcium score after age of 55 to pick up any heart disease early?
Okay, so this
CT calcium score.
Right. So this is what you is electron beam CT CAT scan, which shows what the calcium score is. After the age of 55, as we all get older, we all tend to develop some atheromatous plaques and some calcium. It actually is more for younger population. 50s is okay, but if you're in 70s and 80s, then this test is not going to be that useful. Just the calcium score, but it gives you if you are at a low risk or a high risk, depending on what the calcium score is. As I said before, less than 100, it's pretty good news. If it is 100 to 400, it is mild to moderate disease. More than 400 Agatston calcium score, it's suggestive of severe disease. You need to further work it out.
Thank you. That means CT calcium score should be more useful below age of 55.
Right, but it is more useful in younger population. And as I said, it is also useful in people, those who have low risk pre-test probability. That means they have some atypical symptoms. They are not sure whether they have disease or not. Then you should do a calcium score on them.
Thank you so much. I think we are running short of time, and it's so funny that today it's women heart health. I see more men cardiologists speaking. I know men breaks women's heart, but it's nice to know you fix the heart too. I hope in future there will be more women cardiologists will participate such women's heart health. And here, Dr. Uma Jonalagada, our First Lady is here. She would like to make some announcements. Hi, Uma.
Hi, Udaya. Thank you, first of all, RPQLI, for putting this wonderful presentation about women heart health. And I would say, women, we all wear red. We need to inspire other women, take in charge of your heart health, and mobilize the community, bring the awareness, and also take care of yourself with lifestyle changes. And with that said, I want to invite all of you for the upcoming Global Health Summit at Visakhapatnam, Andhra Pradesh. And this is the first time API is doing over there. So I want all API members, if you can, come and show what API can do with regards to the Global Health Summit. And we chose also inspiring women speakers for the Women's Forum. So come and make it successful. And thank you. Good night.
Hello,
Thanks, everybody.
Thank
you,
Bhavani.
everyone. Yes?
Hello, Bhavani. There's a couple of announcements
Yes.
I want to make. Thank you, Uma. Thank you, Bhavani. There's going to be an International Women's Day celebration again. It will be held in March 8th, Monday at 9 p.m. EST. We will send you the link to everyone. We really request all of you to join. And also the biggest event coming up in person after more than a year, Women's FAPI and API Collaborative Women Physicians Conference on March 19th through 21st at Sheraton, Clearwater, Florida. So I would like all of you to join. Thank you again. Good night, everyone.
Okay.
Let's thank Vijaya Kodali, our administrator, who has done a wonderful job and is the backbone of API, and really did a great job for us tonight. Thank you, Vijaya.
Thanks to everybody who all our attendees who joined this evening and who were able to contribute their attendance, their questions, and all the positive vibes to us during this evening. Okay, good night, everyone, and we'll see you again on another informative seminar. Bye.
Thank you, Bhavani.
Thank you.
Good night.
Good night.
Good night.
Welcome. Good night.